Hello everyone. Renal function tests. Why renal function tests are done? To assess the functional capacity of the kidney for the early detection of the possible renal impairment. And it is also useful in knowing the severity and progression of the impairment. Helps in monitoring the response to the treatment, monitoring the safe and effective use of the drugs which are excreted in the urine. Renal function tests are divided into urine analysis, blood examination, glomerular function test, tubular function test. Urine analysis. Urine examination is an extremely valuable and most easily performed test for the evaluation of the renal functions. The urine analysis includes physical or macroscopic examination, chemical examination, and microscopic examination of the urinary sediment. Macroscopic examination. Color of the urine. Normally it is pale yellow in color due to the pigments urochrome, urobilin and uroerythrin. Cloudiness may be caused by excessive cellular material or protein, crystallization or precipitation of the salts upon long standing at room temperature or in the refrigerator. If the sample contains many red blood cells, it would be cloudy as well as red in color. Specific gravity increased in lower water intake, diabetes mellitus, albuminuria, acute nephritis, and specific gravity decreased in absence of ADH hormone, renal tubular damage. Isostenuria is persistent production of urine of fixed specific gravity, seen in multiple myeloma and renal failure. Low specific gravity urine is isoosmolar with plasma despite variation in the water intake. Urine pH ranges from 4.5 to 8. Normally it is slightly acidic, lying between 6 to 6.5. After meal it becomes alkaline, and on exposure to atmosphere the urea in urine splits into ammonia and results in alkaline reaction. Microscopic examination of the urine sample. A sample of well mixed urine, usually 10 to 15 ml, is centrifuged in a test tube at relatively low speed around 2000 to 3000 rpm for 5 to 10 minutes, which will produce a concentration of the sediment or cellular matter at the bottom of the tube. A drop of sediment is poured onto a glass slide and a thin slice of glass or a cover slip is placed over it, and the sediment is first examined under low power to identify the crystals, gas, squamous cells and other large objects. Gas are the plugs of materials which came from the individual tubules. The number of gas seen is usually reported as the number of each type found per LPF or low power field. Then examination is carried out at high power to identify the crystals, cells and the bacteria. The various types of cells are usually described as the number of each type found per average high power field. For example, 1 to 5 WBC for high power field. Microscopic examination also includes epithelial cells, and 1 to 2 WBC or pus cells per high power field is normal. If more leukocytes per each high power field appear in non-contaminated urine, the specimen is abnormal, showing pyuria. Leukocytes have lobed nuclei and granular cytoplasm. Usually the WBCs will be granulocytes. White cells from the vagina in the presence of vaginal and cervical infections. The extraurethral meatus in men and women may contaminate the urine sample. Presence of granular cas, RBCs, bacteria, glucose, albumin and ketone bodies are abnormal. Hematuria is the presence of abnormal number of red blood cells in urine due to any possible causes like glomerular damage or tumors which erode the urinary tract anywhere along its length, or kidney trauma, urinary tract stones, acute tubular necrosis, upper and lower urinary tract infections, nephrotoxins. Red blood cells may stick together and form red blood cell casts. Such casts are indicative of glomerulonephritis with leakage of RBCs from glomeruli or severe tubular damage. White blood cell casts are most typical for acute pyelonephritis, but they may also be present with glomerulonephritis. Their presence indicates inflammation in the kidney. Serum creatinine. Creatine is a breakdown product of the creatine phosphate in the muscle, and it is usually produced at a fairly constant rate by the body depending upon the muscle mass. Creatinine is filtered but not reabsorbed in the kidney. Normal range of the serum creatinine will be 0.8 to 1.3 in men and 0.6 to 1 milligram per deciliter in women. Not increased above the normal until the glomerular filtration rate less than 50 ml per minute. The methods most widely used for the estimation of the serum creatinine are based on the Jeffs reaction. This reaction occurs between creatine and the picrate ion formed in the alkaline medium because of sodium picrate. A red-orange solution develops which will red colorimetrically at 520 nanometers. Increased serum creatinine is seen in impaired renal function and when very high protein diet anabolic steroid users and in very large muscle mass like bodybuilders, giants, acromegaly patients, crush injury or rhabdomyolysis, and in athletes taking oral creatine, and the persons who are using drugs like probenecid, cimetidine, triamterene, trimethoprim, or amyloid. Urea is the major nitrogenous end product of protein and amino acid metabolism produced by liver, and it is distributed throughout the intracellular and extracellular fluid. Urea is filtered freely by the glomeruli. Many renal diseases with various glomerular, tubular, or interstitial or vascular damage can cause an increase in the plasma urea concentration. The reference interval for serum urea for a healthy adult is 10 to 40 milligrams per deciliter. Plasma concentration also tends to be slightly higher in the males than females. High protein diet causes significant increase in the plasma urea concentration and urinary excretion. Measurement of plasma creatinine provides a more accurate assessment than urea because there are many non-renal factors that will affect the urea level. The non-renal factors that can affect the urea level: mild dehydration, high protein diet, increased protein catabolism, muscle wasting as seen in starvation, reabsorption of the blood proteins after a gastrointestinal tract hemorrhage, and treatment with cortisol or its synthetic analog. States associated with elevated levels of urea in blood are referred to as uremia or azotemia. The causes of urea plasma elevations are prerenal renal hypoperfusion, renal acute tubular necrosis or ATN, postrenal obstruction of the urinary flow. In humans, uric acid is a major product of the urine catabolism, nucleosides, adenosine and guanosine. Urines are derived from the catabolism of dietary nucleic acids and from the degradation of the endogenous nucleic acids. Overproduction of the uric acid may result from the increased synthesis of these urine precursors. In humans, approximately 75% of the uric acid is excreted and it is lost in the urine. Remainder is secreted into the gastrointestinal tract. Renal handling of uric acid is complex and it involves glomerular filtration of virtually all the uric acid in capillary plasma entering the glomerulus. Then reabsorption in the PCT or proximal convoluted tubule of about 98 to 100% of this filtered uric acid. Then subsequent secretion of this uric acid into the lumen of the distal portion of the proximal tube. Further reabsorption takes place in the distal tubule. Hyperuricemia is defined by serum or plasma uric acid concentration higher than 7 milligrams per deciliter in men or greater than 6 milligram per deciliter in women. Glomerular function test. Glomerular filtration rate is the best measure of the glomerular function and the normal GFR is approximately 125 ml per minute. When GFR decreases to 30% of the normal, it is moderate renal insufficiency. Patient will remain asymptomatic with only biochemical evidence of decline in the glomerular filtration rate. As the GFR decreases further, severe renal insufficiency characterized by profound clinical manifestations of uremia and biochemical abnormalities, acidemia, volume overload, and neurologic, cardiac, and respiratory manifestations will occur. When GFR is 5% to 10% of the normal, it is end-stage renal disease. Inulin clearance and creatinine clearance are used to measure the glomerular filtration rate. Creatinine clearance is a simple, inexpensive bedside estimation of this glomerular filtration rate. Glomerular filtration rate is equal to the urine flow rate V into creatine's urine concentration UCR by creatine's plasma concentration or PCR. PFR is equal to V into U creatinine by P creatinine. Normal values is 100 to 120 ml per minute and decreased renal reserve is 60 to 100 ml per minute. Mild renal impairment if it is 40 to 60 ml per minute. Moderate insufficiency 25 to 40 ml per minute. Treated as renal failure when it is less than 25 ml per minute. End stage renal disease if it is less than 10 ml per minute. Tubular function test. In the tubular function test, there will be urine concentration test. The ability of the kidney to concentrate urine is a test of tubular function and it can be carried out readily with only minor inconvenience to the patient. This test requires a water deprivation for 14 hours in an healthy individual. A specific gravity of more than 1.02 indicates normal concentrating power. Specific gravity of 1.008 to 1.010 is isotonic with the plasma and indicates no work done by the kidney. The test should not be performed on a dehydrated patient. Vasopressin test. It is patient friendly than water deprivation test. The subject has nothing to drink after 6 pm. 8 pm 5 units of vasopressin 10 is injected subcutaneously. All the urine samples are collected separately until 9 am the next morning. Satisfactory concentration is shown by at least one sample having a specific gravity above 1.020. Plasma osmolality ratio should reach 3 and values less than 2 are considered as abnormal. Para-amino hippuric acid clearance. Maximum secretory capacity of the tubules for pH is nearly constant at about 80 milligrams per minute. A decrease in this indicates tubular damage. Micropuncturing. Micropuncturing various parts of the tubules and analysis of the fluid for volume and composition. Microscopic study. Studying slices of the renal tissue at different levels. Microelectrode study depth. Measuring the membrane potential of the tubular cells. Thank you for the patient listening. Please subscribe Dr. Ravichandra Official for more videos.